Hello, friends, and welcome to the Research Evangelist podcast educational series. I'm your host, Dave Bjork, lung cancer survivor and patient advocate. And this first podcast series, in partnership with LUNGevity Foundation, is supported by an unrestricted educational grant from Pfizer Oncology. And this is a three-part series dedicated to shared decision-making in non-small cell lung cancer. If you've ever been affected by a lung cancer diagnosis, you know how quickly everything can happen. So, you go from hearing a diagnosis to being asked to make complex treatment decisions, sometimes within days. And those decisions aren't simple. They involve trade-offs between effectiveness, side effects, quality of life, and uncertainty. And this podcast series is about helping make those decisions more understandable and more collaborative and more human. And so today we're starting with the foundation, which is what is shared decision-making in non-small cell lung cancer, and why does it matter so much? So I'm joined today by my friend, Dr. Eric Singhi, a thoracic medical oncologist at MD Anderson in Houston, who works with patients navigating these decisions every day. So Dr. Singhi, Eric, because we're friends, I call you Eric. Welcome
Absolutely.
to the program, and thanks for being here.
Thanks, Dave. Thanks for having me, and really excited to unpack a conversation about something I'm really passionate about, shared and informed decision making.
Awesome. Well, it's really great to see you, and I always love working with you. So I know that your perspective is going to be really important, and it'll be very meaningful to people who will be able to see this podcast series. So let's start simple, Eric. Let's when we hear the term shared decision making or informed decision making, I know some of our friends like to use that phrase. We hear that a lot, but what does it actually mean in practice?
Yeah, I think this is a great question. It's a really big question. It's an important question. I think you're going to get different answers from every person that you ask. If you ask me, when we talk about shared decision making, what we actually mean by that is that truly the best cancer care isn't just evidence-based. And we are obsessed with evidence. This is why we have all of these Congress meetings, why we have all of these research studies, right, to get that evidence. But cancer care isn't just evidence-based. It's truly values-based. And partnership is so important. So my job is to bring the science. It's to bring the data, to tell us what the data says, what are the options, what to expect. But it also means partnership with the patients and their families. And patients will bring something just as important. They're going to bring their goals. They're going to bring their priorities, their life outside of the clinic, because I can't make assumptions about that. And it's so, so important because two treatments can look very similar on paper, but can feel completely different in real life for each patient and their family. And so that really encompasses, I think, broadly what the definition of shared decision-making means.
Yeah, and so it's not just about presenting options to the patient, which is part of the process, but it's really about making sure the patient is really truly part of the decision, right?
Absolutely. Yes, that partnership.
Yeah, and so talk to me about that partnership, and again, in your clinic, when you see patients, and you're trying to present option. I think nowadays there's so many more options than they had, even 10, 15, 20 years ago, that you can put treatments side by side. And like you said, talk about the evidence, but what kinds of things do you think are really important and critical for you and your clinical care team, to when you're talking to a patient about shared decision making, do you use that phrase, or how do you kind of start that conversation?
Yeah, I really like the word that you said a couple of times there, Dave, and that was options. It is a beautiful thing, but also comes with nuances, right? To have options for our patients with lung cancer. Maybe 15 years ago, we didn't have options. We had an option, right? And so it's nice to be able to have options. And I truly believe that patients need to understand that there are multiple options. And it's a disservice if we don't talk about all those different options, right? The emphasis here is that lung cancer has truly become one of the most personalized fields in medical oncology. And we're no longer asking what's the best treatment. What we're asking is what's the best treatment for this specific patient with this specific biology at this specific moment. That's really what personalized medicine means now. And so we have lots of different options, targeted therapies, immunotherapy, chemotherapy. Sometimes we're even using combinations of these different drugs. And then we have biomarkers that completely change the treatment path. And so very often, more than often, there's more than one reasonable option. And I think that's where shared decision making becomes so important, so essential, because there isn't just a single right answer. there's a right fit. And I think that's a big nuance and a difference there.
Do you think patients understand? I mean, first of all, the phrase shared decision making, but do they understand that, or how do they respond when you say it's really about this partnership and about what's right for you as the patient? It's not just something I pull off the shelf because I give it to everybody or whatever. Like, how receptive do you find the patient and maybe their care partners, who are involved with that conversation?
Yeah, this is a really good question. So every patient is different and every patient's family is different and their support system is different. And so as medical oncologists and as oncology providers, we have a really tough job. We walk into the room, and if we're meeting a new patient and their families, we very quickly have to also learn about them. Who are we meeting? Their health literacy, their ability to help really become partners in their care and make decisions. That has to happen very quickly so we can really have informed and shared decision making. Our good friend Jill Feldman talks about both. You can't have shared decision making without informed decision making. And so informed decision making means you lay out all the options, you talk about the potential side effects, you talk about the schedule, and then you can have shared decision making where you can use that partnership, right? Where, okay, yes, I've talked about all the data, I've talked about some of the uncertainties that may be there. And then now we need to use your values, your priorities to make a final decision on what's the perfect fit. And so I truly believe they both have to go hand in hand, and you have to get to learn your patient and their family very quickly so you can really have a successful partnership.
Is there, I know that we're talking specifically about non-small cell lung cancer, but are there things within, you mentioned a couple of things about lung cancer specifically about the different options and biomarkers and immunotherapies and all these different
Yeah.
treatment options. So I guess my question is, is it shared decision making in other areas as well too, like in breast cancer and whatever. But is there? Do you see there's a specific thing that's important, especially important in non-small cell lung cancer?
Yeah, I mean, what I think is different and exciting about lung cancer and why it's a privilege to be a thoracic medical oncologist today as of 2026 is what you said. We have options. And the reason why we have options is because we're better understanding the biology of the tumor. And so what I like to say to patients and their families when I meet them the first time is that I don't just treat lung cancer, I treat your lung cancer. And what I mean by that is I'm really trying to match my treatment options with the biology of the cancer, and then also trying to match my treatment options with their lifestyle, my patient's lifestyle. So lung cancer has truly become the poster child of precision medicine and personalized medicine. And sometimes we get so focused on the biomarkers and we get so focused on the data and we're like, oh, that's personalized medicine, that we forget the word person is in personalized medicine, right? And so I think that's my plea to people is do not forget that the word person is in personalized medicine. And I think that's a reminder and about the importance of shared decision making.
Right. And are there differences? Do you see differences in your practice between, you know, certainly you're talking about seeing each individual patient as a person, as their you're treating their lung cancer. You're not treating lung cancer, you're treating their lung cancer.
Right.
Um, what do uh, patients and their care partners, in your experience, what do they care about the most? And is it different based upon their background, their age, their where they are in their life? Like, what kinds of things do you hear from patients or that you think are important to patients? What do they care
Yeah.
about?
This is, I think, really how you get into shared decision making. This is the devil in the details, if you will. Like this is really the important part. And so what matters most to patients is often different than what we assume. I can tell you that hands down. Yes, outcomes matter, how long our scans can be well controlled with the drug that you're on, how long patients are living, but so does how you live during treatment. And so patients will ask me questions like, can I keep working? Can I take care of my family? How often do I need to come into the clinic? These are really important questions, and the answers will vary from person to person in terms of what they truly prioritize. And one concept that is really important, I believe, is time toxicity. And that means how much of your life treatment takes, right? How much of your life are you having to spend related to cancer care? quality of life, independence, and predictability also matter a ton. And so I think you won't get a sense of what patients are prioritizing unless you ask them. And when we ask, we have to learn to listen, right? I think that's also really important.
No, and that actually leads into the next question I had for you, which I think is perfect segue is, so walk us through what this looks like in a real clinic visit.
Yeah. So I think everyone's going to do it differently. I focus on patient education and patient education research. So I've done a lot of prospective things, retrospective things, trying to better understand how we can continue to fine tune this in clinic, right? And so more to come on that in the future as well. But I think in a real clinic visit, shared decision making is truly a conversation. It's not a lecture. I think that's one big pearl. And it starts with us as oncology providers really translating all of these complex science details into something that's truly understandable. And then we walk through the options. We walk through the benefits, the risks, the trade-offs. And I think, emphasizing important questions throughout are actually really important. And the most important questions are actually, Dave, probably the simplest ones. So what matters most to you right now is a question that I ask very often. What are you most worried about as you think about treatment? And then another one that I ask is, how do you feel about these potential side effects versus potential benefit? And I think those are really good questions to start with. And then you can get into some of the more practical questions like, tell me, what does a good day look like for you? What does a normal day look like for you? What are you hoping treatment will allow you to do? Because those answers that the patients give you will shape everything. And I think that's really important.
Yeah, and I think you touched on some really important things and resonate with me because I feel like oftentimes I hear assumptions, whether it's from physicians or whether it's from patient advocates, that quote unquote, a patient with stage 4 lung cancer is gonna do anything. All they care about is getting the best efficacy, and they'll endure anything.
Right.
And I don't like when I hear that because I don't think that that's necessarily true, right?
Yeah. And I'll tell you too, Dave, my focus is young onset lung cancer. So the majority of my patients in my clinic today are actually under the age of 50, which is how we define young onset lung cancer. Nationwide, that makes up about 10 to maybe 15% of cases of newly diagnosed lung cancer. So it's not the majority of patients in clinics, but in my clinic, it tends to be. And I hear about these assumptions all the time about these young patients with lung cancer. Like you said, they're going to be really tough. They're going to want to endure everything for efficacy. But that is not always true. If you go in with that bias and you say, okay, I know that my patient's only going to care about efficacy, how long progression-free survival, how long overall survival, and I'm not going to focus as much on quality of life, you may make the wrong assumption. Not every young patient is the same, just like not every older patient is the same. And so you have to ask about what they prioritize, time toxicity, the toxicity profile, the drugs that you're prescribing. All of that matters.
Yeah, and you mentioned side effects, and um, it feels like maybe sometimes they're introduced after a decision is made of
Yeah.
which treatment. So we're going to give you X, Y, Z, and here are some of the side effects that you're going to be managing that we hope to manage. But should that be part of the decision process earlier?
Yes, yes, yes. I like that you said it like that because sometimes you're right. Sometimes we in the oncology community use side effects as just a footnote, right? But they're not a footnote. They have to be part of the decision, especially as we have more options now. Because I truly, truly believe that our treatments that fight cancer, they're not just treating cancer, they're truly shaping someone's daily life. And so some patients are going to be more willing to accept more side effects for a higher chance of response. We've talked about that. We've touched about that. But others are going to prioritize having more stability, having more independence, having fewer clinic visits, which is completely different, right? And so the answer may be different. I want to emphasize that there's no wrong answer, but there can be a wrong approach for someone, right? So I think no wrong answer, but there can be a wrong approach for someone. And that's making the decision without discussing those trade-offs early. I think you have to discuss them early.
Yeah, and I wonder if sometimes I wonder if certain clinicians are because they're kind of set in their ways, like this A versus B, but they've always used A, even though does that happen in real
Absolutely.
life? You think where they're just given what the doctor thinks is the doctor knows best kind of thing, like I'm going to give you this treatment without
Yeah.
having that conversation.
Absolutely. I mean, I think there's something to be said about familiarity, right? And so we've looked at this actually. I actually helped develop a survey study where we were trying to figure out, We have multiple approvals for different immunotherapy drugs, for example, in non-small cell lung cancer that is advanced, that is stage 4. And we wanted to figure out, okay, if we have all these different approvals and all these different options, why is there usually one immunotherapy drug that's being chosen over another? And we surveyed different oncology providers around the globe a few years ago. And what we learned was that the number one reason why people kept choosing the same drug over another, despite having the menu of different options, was because of familiarity. We are all humans, right? We're going to gravitate towards the familiar. And anything, kind of takes us away from that, presents more of a challenge, but from a time perspective, from an understanding perspective, from a counseling perspective, you're less likely to do it, right? But I do think that's still a disservice to the patient if maybe on that menu you have an option that might better fit their lifestyle, that might better fit their values. It needs to be explored and discussed.
Yeah, and I think it kind of goes back to that, you know, partnership and I love that you use the word partnership because, you know, I'm so refreshed the fact that we're moving away from that sort of, well, like my parents' generation, it was like whatever the doctor says, I'm just going to do whatever the doctor. So we're kind of making this transition to making a patient and their care partners more involved with these decisions. Do you think that like the side effects um, might actually drive some people's decisions, or is that just part of the series of questions and that you're asking patients?
Yeah, I mean, I think it's one of the questions you definitely have to ask. Oftentimes, if you've got multiple options with similar efficacy or around the same range, leaning in on the side effects, what they look like, how well a patient may be able to tolerate or not tolerate, accept those risks for different toxicity profiles is absolutely could be, the deal breaker for one regimen and more of a preference for another. I think I want to go back to the point that you emphasized about how we're moving away from paternalistic medicine to more partnership in medicine. And yes, I'm a big believer in that. I'm always talking with all the trainees at my institution about shared decision making, informed decision making, the importance of that. But I do want to also say that some patients still come in and say, hey, listen, I'm really overwhelmed. I understand that there is this option for shared decision making. There is this option for informed decision making, but I want you to tell me what to do. And so I also want to emphasize today, Dave, that shared decision making doesn't mean that your oncology provider can't help put their money down and say, okay, hey, listen, these are all the options. I think this option may be best for you, and here is why. I do think we have to put our money down on a potential option so we can guide patients. It's not an excuse to just give your laundry list of options and then let the patient decide. I think we should also still be putting our money down and trying to account for their values and say, I think this option might be better, and here is why.
Yeah, that's a lot of art, not science there. It
Yeah.
seems like, right? How do you navigate those conversations? Because, when you're thinking of, and I know a lot, I remember when I was diagnosed, but I often see people who are newly diagnosed who just like, it's like all hands on deck. Just get this thing out. Just do it now. Just do it. You know what I mean? And it's almost like they're not taking the time to like understand the different kinds of options, and they might just rely on you as their doctor to get. So I like the way you said that. It's you're sort of guiding them, but I think this might be, and then give them the reasons why. But because sometimes there are a lot of differences in the number of visits, or is it a pill versus an infusion, and these are quality of life, uh, decisions that affect people as like you said as humans. That and because sometimes there's striking difference, in like the commitment that has to be made for a particular treatment. But if that means you're going to live X number of months longer, is that the choice? Because I'm going to have to endure going get infusions and all these terrible side effects and whatever. So um, I really like how you approach it, and it's one of the reasons I was really excited to have you on the show because I know how much this means to you, and the fact that you're training the next generation of physicians, to be thinking about this, I think is really important as we move away from that. So Eric, where does shared decision making break down?
This is a great question, and this is an active area of research that I'm really passionate about. I'm leading several different efforts focused on this exact question, right? Um, Dave, the process of shared decision making is absolutely powerful, but you're right, it is not easy, and there's several reasons why. I think first, patients are very overwhelmed. There's a lot of anxiety that comes with the cancer diagnosis, especially if it's brand new, right? Often patients will just have been diagnosed with the big C, and then they're dropped into meeting a medical oncologist, and then it's time to figure it out, right? So the anxiety is high, patients are overwhelmed. I think second, there is a time constraint. Visits are short. At most for a new patient, 1 hour, right? But oftentimes it may even be less. And so we're constrained by time. And I also think sometimes people feel like they shouldn't push back or ask questions. And I think patients, that narrative sometimes has been very predominant where people think that they're not allowed to push back or ask questions. And that shouldn't be the case. You and I both know that, but not everyone knows that. And so I think we have to actively create space for that. And what I mean by that is slowing down when it matters, trying to use tools, educational tools like decision aids, for example, if they can guide decision making, and involving the full care team. Oncology takes a team. Cancer care takes a team. So it's not just me as the oncologist. I rely on my mid-level or APP. I rely on our pharmacist. I rely on my amazing oncology nurse. So it takes a team, I think. And I think those are some strategies to help us make those decisions together.
And just for our listeners, what is an APP?
Yeah, this is an advanced practice provider. Many of oncology clinics and practices will have an advanced practice provider, like a nurse practitioner or a PA or physician associate. And they are an incredible extension of myself and oncologists who provide exceptional care to our patients with cancer.
Yeah, in fact, I was going to ask you who, with that conversation with the time constraints, seems to me that with shared decision making, that's the time constraints are a reality.
Yeah.
You know, I know that from my own care, that's a real big challenge. And so if in your practice you have APPs, you have maybe nurse navigators, who are having these conversations, not just you, talk to us about how does a patient let's say that in a more of a community setting where they don't maybe have facility doesn't have the resources of MD Anderson, like how can we bring this to those communities as well? And so, kind of what needs to happen to make this more broadly, given the limited resources, how can we help the patients who are not going to MD Anderson or Mass General or wherever?
Yeah. So this is my active area of research, patient education. And so I'm very invested in developing and building tools, educational resources that are in patient-friendly language to help empower patients to truly be a partner in their care. So I think one is investing in research, and that includes patient education research, which is near and dear to my heart. I think second, patient advocacy groups and support groups are incredible. So support and community can sometimes make the difference between decent care in oncology and exceptional care. I truly believe that. And so organizations like LUNGevity, for example, incredible. Different biomarker directed groups like the EGFR resistors, for example, or ALK positive, for example, or the Young Lung Cancer Initiative, which is another group dedicated to young onset lung cancer, have really helped provide community support and resources, educational resources for patients with lung cancer who may not be able to get it at their cancer center or their cancer clinic.
And so these organizations can really help support even the conversations that you're having with patients in your practice, right? So because I feel like it seems to me the average person is not gonna, if you throw out the word shared decision making, it doesn't resonate with the average person like it does with you and I.
It's a buzzword, right? It's a buzzword with
It,
no meaning, or it's a filler word until you make it have meaning, until
but
you
it
have.
makes, I mean, the actual words make sense. Shared
Yeah,
decision making. You're sharing the decision making with your patient, and the patient is sharing the decision making with you and your care team,
yeah,
right? But the phrase, that's why I'm trying to soften that phrase so it doesn't intimidate people. And I'm sure places like LUNGevity and others, are helping in those conversations so people can get more familiar with that. And to your point, Eric, about this getting away from the paternalistic approach, which I think is different now. I mean, because I remember when my mom was sick, and I remember my dad just, anytime I'd ask a question, he just gave me that
yeah,
glance, of like, how dare you ask this doctor, this brilliant doctor, questions. But I would suspect that most people in your position, want to have that shared conversation with patients. It's just evolving over time, right?
Yeah, and I'll tell you, some of the most valuable lessons that I've learned in oncology and in cancer care have come from my patients. And so I think we can all learn. One of the foundations and staples as a physician is continued education. And I think we can be educated by patients and families all the time. I learn something new from patients every single day.
Yeah, yeah. So when 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 shared decision making works well, like, so then what changes? Like what?
Everything changes is my answer. We can stop there. Uh, no, I mean, you can tell the difference. Patients feel more confident. They trust the plan. They're engaged in the plan. They're going to want to stick to the treatment plan. They're more likely to stick with it. We have data that shows us that if patients truly feel like partners in their treatment decision making, they are more likely to be adherent, to stick with that treatment plan. But beyond that, it restores something really important that they didn't have initially, and that's a sense of control. A sense of control in cancer, right? Which is speaks volumes about being able to have that feeling, because cancer a cancer diagnosis really takes a lot away from someone, and this is one way we can give some of that back to somebody, and I think that's really meaningful.
Yeah, and I think that you mentioned staying on treatment, and having realistic expectations. I personally, and I don't know why, but personally, I don't like the word adherence. Or compliance. I know that these are phrases that have a meaning, but it's almost like it feels like we're blaming the patient if
Jeez.
they don't stay on their treatment or they miss appointments or whatever, that they're non-compliant,
Oh, I
right?
hate that word. Yeah, yeah. Non-compliant is like just not. I absolutely despise that word. Because you want to understand why. There's a lot of different reasons of why someone may not do something. And if you don't understand the why and you just put that label of non-compliant, the stigma with that and the blame that goes on the patient is completely counterintuitive to what we're trying to achieve. And that's trying to achieve better outcomes for them, better meaning quality of life. But yeah, I can't say enough about how much I despise that word.
I know for some reason when I do a lot of work in clinical trials and bringing the patient voice to clinical trials, and every time I see that phrase, it's like, or I'll hear it in talking with some of my clinician friends. It's like, well, there's a patient that missed all their appointments, but then they find out, through the social worker that there was a patient that was actually living in his car in a Walmart parking lot and didn't have any gas money,
Oh no.
and so she arranged to get a gas card, or whatever. So it's back to the entire patient, right? It's not just the time that's spent, in the clinic. But I could go off on that topic, for a long time.
Yeah.
But so really, Eric, it's about the decisions themselves, and I mean, it's not just about the decision itself. It's about the relationship and the experience that you're trying to bring to the patient,
Hmm.
right?
Absolutely. Absolutely true. Absolutely true. You have to respect the whole patient. We're not just trying to treat the cancer, we're truly trying to take care of the person with cancer. And I think that's a really big distinction. And we need to be emphasizing holistic care.
Yeah. Um, So, if you could leave patients with one piece of advice when it comes to decision making, what would that be?
Well, this is a good question. I would say you don't necessarily have to have all the answers, but I do think your voice has to be part of the conversation. And I'm a strong believer in that. And I think what I would also say, Dave, too, is there's rarely one right treatment, but there is a treatment that's right for you, right? So not just one right treatment, but there may be a treatment that's right for you. And I think that's really important to emphasize.
Yeah, I agree because everyone's lives are different, and sometimes we talk about side effects, grade 1, grade 2, grade 3. Like these are, what might be tolerable. It's another one. It's another one of those like making assumptions that, oh yeah, it's only grade 2 diarrhea, whatever. It's like, yeah, but if again, be empathetic and put yourself in the position of a patient, like
Yeah,
that. It might not. You mentioned earlier, it might not be what the top priority of what a clinician might be thinking about. And so this divergence of what's important to a patient might not be the same as it is for a physician, which to me is a perfect opportunity to build a partnership,
exactly. Yep.
right?
Don't make those assumptions, figure out what they prioritize, and then include that in your decision making. That's what shared decision making is all about.
Yeah, yeah. So any other final thoughts or things that, again, we're here speaking to patients and care partners, but also clinicians as well. So are there any other final thoughts or words of wisdom that you can share with us, about this particular topic?
Yeah, I mean, I think to my physician colleagues, what I would say is that in medical school, in training, we don't ever get formal education on shared decision making, on mastering communication, on translating these really complex topics that we learn about for years, for over a decade, to be able to deliver excellent cancer care. But I do think investing in the time to improve upon your communication, investing on the time to include educational resources and how you're guiding patients through treatment decision making is so important. And so my plea is have an open mind, have an open conversation with patients and their families. And then to patients, we talked a lot about shared decision making. We talked a lot about informed decision making. There's also this other buzzword, and that's the empowered patient, right? And sometimes that word can be really intimidating where people think they have to know everything. And that's what empowered means. That is not true. What it means to me to be an empowered patient is that you have to feel included in your cancer care. And so if you feel included and your team has really created that space for you, that is the gold standard. That is what you need to really have comprehensive, exceptional cancer care. And so don't be overwhelmed by the term empowered. Embrace it, understanding that it really just means that you feel included.
Which again goes to the work that you do and the research that you do, Eric, in terms of educating patients on these types of decisions. And I agree. Like when we say empowered or even advocate,
Yes.
it's like advocate means different things to different people, right? And so same with with empowerment, because every person has a different personality, right? Some people are going to go in there guns a-blazing, like with notes and questions and all, you know what I mean? And others are, that's not their personality. And there might even be difference between men and women. And man, there's all kinds of different, or caregivers might see things that, that the patient's not
Yes.
noticing, right?
So
With
true. Very
like
true.
maybe with the CNS effects or mood changes or whatever, right? So I think this partnership idea, the more I believe in teamwork, and I believe we're all in this together. So the more we talk about this partnership of you as the doctor, your team, the APPs and navigators, maybe social workers, others that that are going to be having these conversations with people, and let's not intimidate patients. And so that's kind of what my goal is with this series, is to really start having these, me sharing from my platform these conversations with people like you. Um, we're trusted voices in the community, and so I want people to feel comfortable and understanding what we're talking about. And if there's questions that they can bring to their care team, or they can have their care partner, come with questions or whatnot. So, but I think this is a really powerful place to end. And shared decision making isn't really about just finding the perfect treatment. It's about finding the right treatment for each person. And you've made that very clear, which is, I think, is really important. So in our next episode, we're going to focus on the patient voice and the patient perspective. And so we're going to talk about what matters most, and what often goes unspoken, and how patients can prepare to take an active role in their care. So that'll be the next chapter. But thank you for saying this foundation, Eric, for what is shared decision making, why is it important in non-small cell lung cancer, and I really want to thank you again for joining us, and thank you so much for everything that you do for the lung cancer community. I really appreciate it, and this is really important. So thank you so much.
Thanks for having me, and thanks for creating a safe space to be able to unpack this. I really love spending time with you and learning from you.
Awesome. Thanks again, Eric.
Take care.